Good afternoon. This is Dottie Howell, the Communications Director at the Ohio Health Information Partnership, also known as CliniSync Health Information Exchange. Thanks so much for joining us today.
Good. Thanks, Dottie. Hi, everyone. Thanks so much for joining us. What we found when we did this presentation on Monday is there were so many questions, and everyone has a slightly different fact pattern, that we will definitely try to keep on our scheduled time so we can answer everyone's questions. If in fact we don't have the opportunity to answer a question or you still have concerns, feel free to email either Scott or myself. Our emails are at the back of the presentation. And just so you're aware, I think many of you have heard us before on presentations, and you know that we try to keep it pretty succinct. This presentation is really detailed, and the reason why is this rule is fact-driven. It is definitely fact-driven by specific scenario for each practice and hospital, and consequently it makes it very auditable. And so everything in this rule, it is going to be necessary to create audit documentation to cover yourself for your 2014 attestation. We have a complete section on the audits and what information you're going to need to preserve as part of your 2014 attestation, but just so you're aware, that's why there are so many details here. Let's talk about the rule itself. This is the follow-up to the proposed rule that was put out in May, and this was released in final form September 4th, so just last week. The significance is, and although it was a follow-up rule, let me just say that the final draft was 3 times as long as the proposed rule. So that gives you an idea that there's a little bit more in it than just what you saw in the proposed rule. Why did CMS do what they did, and why is it as detailed as it is? Let's just set the stage, which all of you out there in the field, I feel your pain. You know as well as we do that this was a very difficult process for 2014. Even when it was first proposed in 2012, the timelines were extremely short for the vendors. You're looking at less than a year for them to get all their systems upgraded, get through a certification process, and it's a process that many of them are still going through. And then it required everyone to turn around and get that information out in the field to get the upgrades installed, to get you all trained in practices, and I'm sure many of you will attest to the fact that that process is not complete either. Part of the problem was that there are 350,000 providers that had attested as of 2 or 3 months ago. So that you're talking at 350,000 individual upgrades that needed to occur. The other problems is, as we said, the vendor issues. Big issue was CQM reporting, and I'm sure I have a lot of people nodding their heads out there, because I have not been to a place in the past 4 or 5 months where CQM reporting is not an issue. When those measures were put out for 2014 Stage 2 certification, 100% of the CQM measures had technical problems. So that followed through, and the vendors have had a hard time getting certified on those, partly because the original technical specs had problems with them. So they're trying to get caught up on that. But this is all stuff that basically lays the stage for what you all are doing and any issues you might have. To date, as of just a week or two ago, there are only 3,000 eligible professionals that have attested to Stage 2, and only 143 hospitals nationally. We're not talking in Ohio, we're talking nationally, who have attested to Stage 2. So there are a lot of issues. Let's look and see, as CMS tried to create a patch to cover this problem so that people could report in 2014, it required some fancy footwork to figure out where the problems were and how they were going to address them. Let's talk about what the rule doesn't do, because I want to make sure that everyone that can possibly attest does. And since a lot of things were up in the air with the proposed rule, I think it's really worthwhile to review when you need to attest. You hospitals, you are going to have to attest by November 30th of 2014 for 2014 attestation. The last period that you can run your reports are July 1st through September 30th, attestation being by November 30th. However, with that being said, if you've had problems, and we'll talk about this in a minute, you can look back and use a prior quarter in 2014. It could be October through December of 2013, January through March of 2014, April through June of 2014. Can also be used as your reporting period, and you just need to get that attestation in by November 30th. For physicians and EPs, your reporting period will remain based on the calendar year. The latest attestation period you can run is October 1st through December 31st of 2014. That is for a Medicare attestation. Your reporting period or your attestation has to be in by February 28th of 2015. So latest reporting period would be October 1st through December 31st for Medicare attestation by February 28th. If you're a Medicaid provider, your attestation period will be any 90-day period in 2014, same attestation period, by February 28th. If you are a first-time attester, so first time you've met meaningful use, it's a little bit different, and that depends on whether or not you file for a hardship exception. Because if you are a first-time attester and you are trying to avoid the 1% penalty on your Medicare billings for 2015, then you want to have your attestation completed by October 1st. If you filed your hardship exception for 2014 and you are still working on getting your attestation done, you can attest for any 90-day period up until December 31st, and you will not receive the penalty if you have the hardship filed and you've gotten your attestation done in calendar year 2014. Your attestation period in that case would be, or your attestation process where you actually attest would again be linked to that February 28th, 2015 date. If in fact you did not file a hardship exception, but you cannot meet the October 1st attestation date, you can still run meaningful use. You can run it all the way through December 31st of this year. It's just that you can attest for meaningful use, receive your incentives, but you will also be subject to the penalty in 2015. Important point for everyone, hospitals and physicians, keep this in mind. This is really, I think, uppermost in all of our minds, certainly those of us who work with you out in the field, is that no matter what this rule does or does not do, you have to be ready with all this technology up and running, certified, and ready to go at the beginning of your 2015 attestation period. So hospitals, that means whatever problems you're having now, you're supposed to have your system clean and ready to go by October 1st of 2015. EPs, you're supposed to have yours up and running by October 1st of 2014 for the hospitals and January 1st of 2015 for the physicians. Now, if in fact it turns out that CMS decides to make other changes, they did not do it in this rule, and they specifically said they felt it was outside the scope of this rule to address proposed changes in for 2015 attestation and meaningful use. And I know this has been one of the most heavily criticized parts of the rule, and Scott's going to talk about that, about what some of the groups said nationally about this. But it's just something I want you all to keep in mind. Whatever issues you're having with your vendors and however you decide to attest for this year, you need to get those issues resolved at the start of your reporting period, because everyone will be back to a 365-day reporting period in 2015. Let's talk about what the rule does say and what they mean by what is flexible reporting. What is flexible reporting? And this is something those of you who follow the proposed rule are going to be familiar with this concept because it was pretty much what they had floated in the proposed rule. It's just that they fleshed it out in the final. And it creates a look-back period to stage 1 or to stage 2, depending on what the issues are that you have with your vendor, what technical implementation issues you've had. It does change the requirement that you have to have 2014 certification in order, 2014 certified system installed and running in order for you to attest this year. And we will talk about how that changes. But basically, it allows a look back on the technology side. And it also allows a look back on the meaningful use measures side so that you can use a 2011 system. You can use a 2011 and 2014 combined certification system or a 2014 certified system with different potential meaningful use measures. But how do you know when to employ this? And this is the key issue. When I say this is auditable, I am not kidding. You all have to do this. There has to be an analysis, a flow sheet that you use and go through and then attach the documentation to support your decisions. But straight out of the rule, what the rule says is, quote, the addition of certified EHR technology available to a provider dictates the stage and version of the meaningful use objectives and measures that the provider will be able to meet. So the first part of any analysis is where are you technically? Let's look at the first left-hand column. Has your system received certification? Has your vendor received certification for your version? And if the answer is no, and you have attested before, so you have a 2011 certified system, then you know for a fact that you will be attesting to last year's measures and CQMs, so what they call the 2013 measures. Practically speaking, what this means is you will be attesting, if you're an EP, you will be attesting to the meaningful use stage 1 measures that do not include patient portal, and you will be using the original CQMs, which is 3 required, 3 selected for 2013. If your vendor has received certification, but maybe not if you're a hospital and you're modular and not every module is certified, then you fall in that middle column, at the middle bucket where you have more options as to how you're going to attest. And that will be driven by which functionality is present. So if only part of your system is certified and you don't have an active patient portal, for example, then you clearly are going to go back to the 2013 standards because you can't report on the 2014 measure. If you're at stage 2, you have 3 options that you can attest to. 2013, stage 1, 2014, stage 1, which as we said includes the portal, or 2014 stage 2. If the part that's not certified, the functionality is there and you can collect those measures and CQMs, then you can report on that. If you're fully certified but not fully functional, then you get into if you're fully certified, you get into the right-hand column, which is basically reporting on what you would normally be scheduled to report on, or falling back to the stage 1 measure for stage 2, which means you'd report on your portal, but you would not necessarily report on transitions of care. So we kind of ran through that quickly, but as we get to the questions, we can kind of spend a little more time on the use cases, but just keep in mind at this point in time, your analysis is what is the certification of my vendor? Whether or not they're certified, have I received all the upgrades? And if I've received all the upgrades, have I had the opportunity, or all the bugs out of it, and I had an opportunity to fully implement? As I said, and Scott will talk a little bit about this too, the question of what measures you use are always, as soon as you arrive at your decision, whether you're going to use 2013 or 2014 measures, will also always determine which CQMs you report on. because this is a logic that's built into the attestation. The vendor that has set up the CMS attestation system and the Medicaid attestation, once you decide which track you're on, it will track for that complete set of meaningful use measures and CQMs. So that's when you look back to the whole package. Okay, let's talk about Medicaid for those of you who are Medicaid providers. I just talked to Medicaid about this yesterday, and the rule basically requires all the Medicaid programs to adopt the same flexible reporting option that will be adopted for Medicare. The difference is because it's run by a different vendor, we do not know yet when Medicaid is going to be able to accept the fallback, if you're using 2013 measures. If you're using the 2014 measures, their system is open right now, and you can certainly go ahead and attest to those without any problem. If you have to use this flexible reporting option and you're going to be reporting for less than 2014 measures, then we'll have to wait, and they will let us know as soon as their vendor's ready with that. We do not know if there will be any delays on that. Let's talk about specific measures and how this rule impacts it. Let's talk about public health reporting, because this is a huge area. Obviously, the hospitals at stage 2 are moving to the 3 public health reporting measures: electronic lab reporting, syndromic, and immunization. Most of you are well down that path to getting that done, and if you're doing it through the HIE, Peg Eichner is your go-to person. Those are going to be specific to your site. Most of you are well underway with that. But on the EP side, there are a whole different set of public health reporting issues, because up until 2014, the public health reporting was really closed for the EP side, and everybody took exclusions. So except for some systems and a few individual providers, some of the pediatricians and stuff, a lot of EPs just took the exclusion for immunization reporting, which was the required or preferred public health reporting measure for EPs, was immunization. What this rule says, let's talk about what this rule says and then how it is impacted by Ohio's exclusions that occurred in 2011, 2012, and 2013. So if you are using this flexible reporting option, if you have to fall back to an earlier measure, you are allowed to, and something to keep in mind here is when they say fall back to an earlier measure, you can report on any quarter or any 90-day period before the fourth quarter. I mean, it's any time during the whole year. And so if, in fact, you're having vendor issues and you have to use your 2011 certified system because you're having problems with your upgrade, if you can go back and run a report from the first quarter, the second quarter, or if you're Medicaid from any 90-day period earlier in the year, you can do that and use that for attestation purposes. You don't have to, it doesn't have to be a look forward on the attestation. It can be a look back for any part of 2014. But the challenge here is if you're documenting the other, what we call the functionality issues. And for immunization, if you're using the flexible reporting option, the rule says that you don't have to run that immunization test if you ran it in a prior year and have that documentation. So if, in fact, you did run a test or you were actually submitting to the Ohio Department of Health Impact SIS, then you're covered for your public health reporting measure for stage 1 in 2014. But the problem is a lot of EPs did not run that test because they took the exclusion. So if you have no documentation that you ran that test prior to 2014, then you are going to be required to have that public health reporting test run during your attestation period. So that may limit when you can attest. We're asking for clarification on this because I don't think Ohio was the only state that had taken exclusions to this point in time. But right now, if you have prior documentation, you can use previous year's immunization testing. If you don't, you have to run that, and that will determine when you do your reporting period for 2014. If you are a first-time attester, you will still be required to submit a test message. For stage 2, the public health reporting measure does not change at all. So hospitals, you're still required to meet the 3 public health reporting measures. For transitions of care, this is one of the few measures where they specifically address the measure in the rule. Every other time they say we don't have the authority to change the meaningful use measure. But because of all the transitions of care issues, and let me tell you, CMS received over 1,100 comments about this rule. So people felt pretty strongly about it, trust me. And one of the most cited comments, and CMS said that they had not anticipated both the scope of the problems and the scope of the response, but one of the areas that presented the most problems were a transition of care issues. And so this is the only measure that they specifically go into whether this triggers a look back in and of itself. As you recall, in the stage 2 transitions of care, there's 3 parts. One requires a summary of care record to be sent in 50% of the cases. One requires that in 10% of those be sent electronically, and the third requires a test of transition of care. In this particular case and in this rule, they are only addressing that middle part of that standard. So the question is, can you send 10% of your summary of care documents electronically? Well, as you all know, and you've discovered and you've spent months trying to do, is that as everyone gets up on the direct email system, it requires HIFS certification, requires you to find out your parties that you transition to, what their email addresses are, to have them get up on systems. And in some cases, if you're a hospital and you're sending to long-term care, some of these may not even be on a full clinical EHR system. So it is really important that this be addressed in this rule. So what CMS has said, this is their only exception. You may be meeting all your 2014 measures, every single one of them, but you can't meet that 10% threshold because you have parties that you need to send to, be it another physician's office, be it a long-term care, be it a rehab, whatever your situation is. If that receiving party cannot receive because they're not hooked up through direct or they're not set up to receive transitions of care, and you can document that fact, that they have their own technical issues that prevent you from sending a CCDA to them, then that will be a documented reason to allow you to look back to a stage 1 2014 measure, which would mean that you pick up the portal, but you would not pick up transition of care. So you must retain documentation. They specifically say this is an auditable case. So that's going to be something you have to work out with people that you send documents to on a regular basis. Okay, if your providers are at more than one location, how do you handle that if not all are equally certified or meeting the 2014 certification standards? If less than 50% of the patient encounters are at locations with 2014 cert, then you use the flexible reporting option where you're saying we're using both 2011 and 2014, and you include all patient encounters at all locations if it's less than 50%. If it's more than 50%, are at locations with 2014 cert, then you drop off the locations that do not have 2014 cert statistics, report only on the patient encounters that have occurred at locations with 2014 cert. So as I said, this is a fact-driven analysis. Now what I'm going to do is turn this over to Scott. He's got 2 real important areas to discuss with you. One being the audits and what's acceptable and what is not acceptable documentation for this flexible reporting. The other thing that he's looking at is the whole process drives to how you get your attestation, CMS attestation number through the Chapel website, and that will set you up on how you're going to do your attestation reporting. So let me turn it over to Scott for the next part.
Hi everyone, I hope you're having a good day. Just a quick reminder, please type your questions down in the Q&A box as we go along. At the end, we will run through every question and provide an answer And yesterday we found that really a lot of the questions will provide that clarifying information you need to really build a good understanding of this rule change. So first, let's focus on audits. You know, as Kathy said, this is a fact-driven rule. So there's some specific information that you're going to need to retain should you be audited. We were kind of hoping that we would see at least a semi-pass on audits for this year based on all the problem sites we're having with, you know, just everything from their numerator and denominator reports to their CQMs, but audits are going to continue. Ohio is seeing a large number of audits. Kathy and I have been working with a number of institutions on audit response. If you do get an audit and you need some help with the response, contact Kathy or myself. If you're interested in a mock audit, we also do a mock audit service as well to ensure that should you be audited that you've got the documentation necessary to respond quickly. So again, let's focus back on the rule. This rule change does create some unique challenges with regards to the documentation that you need to retain should you in fact be audited. CMS is very specific with regards to the allowed reasons for utilizing this flexibility rule. They mention this several times throughout the rule, so I feel it's very important that we actually, read the actual text from the rule. Providers who choose this option must attest that they are unable to fully implement the 2014 edition certified EHR technology because of issues related to 2014 edition cert availability delays when they attest to the meaningful use objectives and measures. So what you're really saying is that there are these specific reasons that we've covered today can be demonstrated, and they drove your decision to utilize the flexible reporting option. So there are some acceptable reasons for using the meaningful use reporting option. Besides the lack of 2014 certified product by the EHR vendor, CMS has identified the following reasons why a hospital or a physician can use another reporting option other than the one that they were scheduled for in 2014. So meaning, if you were rolling back from stage 2 to stage 1, or you're rolling back to a 2013. Clearly, the easiest reason to demonstrate the use of this rule is that your EHR vendor did not obtain the 2014 certification in a timely manner. They just didn't get certified or got certified so late that you were unable to implement. So if you have a 2014 cert, but you received it late in the year, then you may be able to make use of the second reason why you can use a flexible reporting option. A provider's inability to fully implement the 2014 certified EHR technology based on one or more delays related to software development, certification, or the release of the product. This one is a little bit more difficult to demonstrate. We didn't get a lot of guidance from CMS outside of one little offhanded comment they made about a large hospital system that received the update in August, but there wasn't any clear guidance. So what we're recommending that folks retain in the way of documentation is the date of the actual installation, the date that the build was complete, a detailed training and rollout plan, and really your goal is to show that you could not complete the build and rollout in a timely manner before the beginning of your reporting period. Make sure all of your documents are dated, make sure your project plan is dated, and really the best proof is if you can get the vendor to fall on the sword and give you a letter that just says, yeah, hey, it's our fault, we got it to them too late, we had some problems, whatever. That's going to be really critical if you can get them to do that. It's not a necessity, but it really would add to the matter of proof. So then the final one is if the 2014 cert is installed, the provider may still use the flexible reporting option if there's delays to vendor software updates, either delayed or missing, software functionality issues such as patches or updates to correct a software bug, or software that's missing some required component or that creates a safety issue. So let's talk about this a little more. What they're saying here, if the vendor was certified in a specific menu measure, when you got the initial release of the software, if it was missing a piece of functionality, they said, hey, we're certified, we're making a change, and then there's a delay with getting that update to you, that secondary patch or hotfix to provide the full functionality, that's a reason. If there is a bug in the software that creates a provable patient safety issue. Let's say it's there's a bug where a drug-drug interaction or a drug-allergy interaction isn't firing for a specific reason. That could be a reason to roll back. But again, you're going to need some documentation to prove this. The documentation that I would recommend, again, is a letter from your vendor. If it was a bug or you're missing a piece of software or something and you entered a ticket into their customer support portal, I would get a copy of that as well, print that out, and any updates that went along with it. Screenshots of the actual bug or error, and a narrative describing the patient safety issue related to that. I'm really big on narratives, as you guys will kind of see as we go through a few more slides. Now, there are some unacceptable reasons, and if you roll back to the 2013 standard based on any of these and you're audited, it's an immediate failure. So these reasons are not acceptable. You cannot claim financial hardship. You just can't say it costs too much. If you say it costs too much to go to stage 2, I'm staying at stage 1, that's an immediate audit failure. If you are unable to meet a specific meaningful use measure outside of TOCs, but again, TOCs there's some caveats around TOCs, but let's say you can't meet the ERX measure if you're a hospital. That is not a reason to roll back. Missing a single measure is not a reason to roll back to the 2013 standard or stage 1. Also, if you have staff changes and turnover, even if those staff changes and turnover delay your build, not a reason. And then if you just waited too long, or if you did nothing, that is also not an acceptable reason and an immediate audit failure. So, well, CMS provides some specific language around how or why the rule can be used. They're a little vague with the specifics of the documentation necessary to demonstrate proof. So really, these are just a few quotes that I kind of pulled out to show some of the vagueness that we're seeing. Auditors will be provided guidance related to reviewing attestations associated with the options for using certified EHR technology. Not a lot of detail on what they're looking for. We believe that such case-by-case review will allow us to adequately account for the varied circumstances that may result in a provider selecting a different cert option. Again, a little vague. This case-by-case review, to me, that's screaming, I need really, really good, hardcore documentation. In this last one, the referring provider must retain documentation clearly demonstrating that they were unable to meet the 10% threshold for the measure to provide an electronic summary of care documentation for a transition or referral. To me, trying to demonstrate that carries the heaviest burden of proof, because you're not saying there that we couldn't meet the measure because of a technical problem we're having. It's we couldn't meet the measure because those that we're trying to send to were either having technical problems or were at stage 1 and didn't have a system configured to meet stage 2. So to me, that has the largest burden of proof. So now let's talk about some specifics around the audit documents that we're recommending that you retain. Again, I'm big on narratives. Narratives, you should have a narrative that clearly outlines your organization's story. So if you're rolling back because there was a delay in the certification, go back through your emails and find where you've corresponded with your vendor. If you can find some details in there to kind of type up a little narrative, great. If you're rolling back due to a bug, you got to have a good narrative to say, here's why this bug is a patient safety issue. Also, a letter from your vendor detailing the certification or other issues. Man, if you've got a good vendor that you're a good partner with and they readily say, hey, it was our fault, perfect. If you can get a nice letter on their letterhead saying that, you're covered. Again, if you're rolling back to software creating a patient safety issue, you're going to want screenshots of the bug. You're going to want to print out your associated case or ticket from the vendor supporting or support system. If they've got a press release, if you can get a statement out of them, something. Now, again, for the TOC, if you roll back due to the summary of care not being able to meet the 10% for the transition of care, that's where I see the biggest problem with getting the needed documentation. You're really going to need something from every potential receiving hospital or provider or long-term care facility that says we weren't ready. We didn't have the functionality. We just, whatever the reason is, you're going to need that from a large number of those that you send out to, because it's a low threshold. It's a 10% threshold. So that carries a very heavy burden of proof. Also, if you are making use of the flexible reporting option, you got to make sure that if you don't perform your public health test, your immunization test, your syndromic test this year, and you're going to use a test from last year, make sure that you have that in your audit manual as well. So, okay, now we're going to talk a little bit about the actual attestation process, and that's kind of a misnomer, because we're going to actually look at the steps that you're going to need to complete leading up to the actual attestation process. Specifically, we're going to look at as Kathy shared earlier, it's your certification ID number that is going to drive your actual attestation process. So when you log into the CMS attestation portal, one of the first questions it's going to ask you for is your CMS, your EHR certified ID number, or certification ID number. There's actually some logic built into that number. So let's say you put in a 2011 certified number, it's going to take you through the 2013 standards. If you put in just a number generated from 2014 certified technology, it's going to take you to the 2014 standard, be that stage 1 or stage 2 for you. If you put in a mix of products that are 2011 and 2014 in your cart, which we're going to run through the process, then it's going to assume you're rolling back to the 2013 standard. So what we're going to look at today is what we commonly call the CHAPL website, which is really the Certified Health IT Product List website. I've shared the URL here. What we're actually going to look at is, I'm not going to do a live webinar. I've got some screenshots of it just to avoid any potential technical problems. So what we're going to do is we're going to run through a specific scenario. I'm going to assume that at my organization, we started our reporting period. We were having some problems. We're running Paragon. We started our reporting period running the 2011 certified version of Paragon, and then about halfway through our reporting period, we updated to the 2014 version. So since we have that split reporting period between the two technologies, I'm actually going to report at the 2013 standard. But I need to make sure I've got the proper ID number to drive that actual attestation process. So what I'm going to do is, I'm on the CHAPL website. I'm going to click on this middle button, which is going to give me the combination of the 2011 and 2014 certified cert. Paragon is an inpatient system, so I'm going to click on this inpatient practice type button. And next I'll be presented with, the search screen. My search criteria, I'm going to use product name and Paragon. Now, just as a little caveat here, when you type in the name Paragon, don't just hit enter. It won't actually take you where you want to go. You want to click on the search button after you put in Paragon. Now this is going to present me with the list of all of the Paragon products. You'll see some of them have a modular certification and some have a complete certification. In this scenario, I'm using the version 11 complete EHR. So what I'm going to do is I'm going to click on the Add to Cart button, and that's going to put it in my cart. You guys have probably all seen this screen if you've went through this process before. Now, if this were a normal reporting year, version 11 is a completely certified product. I would go up here and I'd hit this Get CMS EHR Certification ID button. But I'm not going to right now because I need to add another product. So what I'm going to do is I'll go up here and click on this Return to Search Options link, and it takes me right back to my list. And in this list, you'll see now it says out next to the Paragon version 11 complete EHR. It tells me that that's already in my cart. I'm going to now add the version 12 to my cart. Now, I'm going to stop right here for just a second before I hit Add to Cart. If I had an EHR that had modular EHR certification that was made up of 5 or 6 different components, let's say I've got the base EHR, but I went with another vendor's patient portal, or I've got some e-prescribing module from another vendor, you may end up having 5, 6, 7 items in your cart. But make sure whatever applications or whatever products you use, that you've included them all in the cart. So, okay, now back to the demo. I'm going to go out here and click on Add to Cart next to version 12. You can see that I've got both products now appear in my cart. I'm going to click on the Get CMS EHR Certification ID button. And you're going to want to print this screen. Keep it in your audit book. You can see here, again, it shows all of my products down at the bottom. But the key here is this certification ID number now has the logic built in it that when I enter that into the attestation portal, I will be driven down the path of a 2013 attestation. It's going to be a Stage 1 2013 attestation. So we also think it's important to share some comments from the other organizations. When the proposed rule was released, there were a large number of comments and press releases from different organizations, vendors, providers, kind of in the hopes of what they would see from when this rule was finalized. Some talking about, maybe it was released a little late or whatever. Then CMS, after the release, they had a 60-day mandatory comment period. And during this period, a lot of organizations shared their comments that they had submitted, which again generated a little bit more conversation. And then, as you can imagine, when the final rule finally did come out, there were a huge number of comments from healthcare-related organizations and, again, vendors and providers. And we just feel it's important to share some of these. Just to go down through them real quick, Chime stated that they were deeply disappointed in the decision to require a full-year reporting period for 2015, and that that provision severely muted the positive impacts of the final rule, and has all but ensured that the industry will continue to struggle well beyond 2014. And what I take from that is if you do make use of this final rule, keep in mind that your 365-day reporting period at that 2014 standard, be it Stage 1 or Stage 2 for your organization, is right down the road. It's, October 1st for your hospitals, January 1st for your physicians. So even if you make use of the flexible rule, don't stop working. Keep heading towards that goal. MGMA stated that while they appreciate the rules focus on certified EHR software, many of the prevailing issues with the Meaningful Use program are not addressed. Specifically, the rule ignores some of the meaningful use requirements that have proven extremely onerous and forced eligible providers to rely on the actions of third parties. Specifically, what they're talking about there is the transitions of care measures and the patient portal related measures. Probably the comment that hit me the most was from John Halomka, CIO of Beth Israel. He said that although certified products may have been introduced into the marketplace, the time to implement, train, and ensure safe use exceeded the Stage 2 time limits. And I really like this statement because it focused on what's most important, patient care. So now we're going to talk about some other issues addressed in the final rule, and I'm going to turn it back over to Kathy with a quick reminder. Go ahead, enter your questions down in that Q&A because we are approaching the end, and we'll run through every question.
Okay, everyone. Believe it or not, part of the 90 pages of the new rule included things other than, as we said, the flexible reporting option that had been in the proposed rule. So let's see, for the most part, the other areas that were brought in were ones that you all are familiar with that had been floated or officially proposed in the past, but now they're finalized. Stage 2 is now officially extended to include 2016, so Stage 3 measures will not begin until 2017. The other one, this is a hospital measure. The original Stage 2 rule required for the measure that calculates how many of your lab results you're sending to ambulatory providers electronically. Originally, that was being tracked as how many of them had been ordered electronically and then how many were being sent back electronically. Well, they realized fairly quickly, CMS saw that there were going to be problems with this calculation because not all providers had the ability to send the order electronically. So now the hospitals, and this is a change that had been proposed over 1.5 years ago, so all your vendors should have built it this way. But what it is now is that measure is actually being captured for all lab orders, whether or not they were sent in electronically. How many of those are returned to the providers, the ambulatory providers electronically, and that's at the 20% threshold. The other measure that was specifically changed, and this again is a hospital measure, is the patient portal measure. In the original rule, they had misused it, inserting the word unique patients. And so it looked more like it was in a patient encounter, was the denominator for view, download, and transmit for the patient portal. And they did correct that in this final rule to say that for view, download, and transmit, the denominator is set based upon the unique patients that are discharged from the hospital. So if someone ends up in the hospital more than once, heaven forbid, given the new value-based modifiers for hospitals, but assuming if they do end up more than once or they're in the ED and then come back through and they're admitted, that they are calculated only once. And then the other area, we'll be talking about this more of the next couple of weeks, but are the CQMs. There were a lot of corrections that went into the rule for CQM electronic specifications, but not something you need to worry about today. The other thing, and this is a hospital, pretty much the CAH hospitals, this is an area that has been proposed for them, but it is something that has been out there for months now, so if you aren't familiar with it, you can contact us for more information. But basically, hospitals with 5 or fewer discharges during the reporting period, or 20 or fewer for a year, can claim an exemption for that CQM reporting for that denominator population. But in order to claim that exemption, the hospital must submit aggregate population data and sample size counts to show that they were not able to track, or that the system was, patient volume was so low. And this we see primarily in the CAH cases where, you know, the CAH basically stabilizes the patient and pushes them out to a larger trauma center or referring hospital. But if you're, as I said, you should be familiar, your technical vendors should already know this, but please keep that in mind when you go to a test if you're CAH. So let's to recap real quickly before we get into the questions and answers. The first and the driving factor in using the flexible reporting option for 2014 is you must determine the status of your EHR certification and functionality. Is your system fully certified for 2014, and is it fully functional? It was so 3 prongs: certified, have you received the upgrade, and is it fully functional? If any of those answers are no, then you look at the chart earlier in this presentation and determine what your reporting options are and the meaningful use measures and CQMs that must be reported on depending on the functionality that exists in your non-certified or not fully functional system. Make sure that you track the correct set of CQMs based upon your analysis in the preceding point. Then move on and take that information about what system you are working on and the certification, and as Scott said, go to the Chapel website and get your EHR CMS attestation number for reporting purposes. Enter that in for your attestation, and then either it will push you directly into the 2013 track if you're 2011 certified, or it will give you options as to what you can report on, and you select the correct option based upon your functionality, and then that will lay out the meaningful use measures and CQMs. And then finally, and as we all know, a very important point these days is maintain your documentation for any changes that you make in your reporting period. If you are having vendor issues and continue to have vendor issues, if for any reason you are not able to attest in 2014 even with these changes, please make sure that you file your hardship exceptions so that you do not receive a 2016 penalty. And this would be due for the hospitals on April 1st of 2015 and for the EPs July 1st of 2015. That's it. That's our final part of the presentation, and as we said, based upon our previous presentation, I'm sure there are a lot of questions, so we're just pulling this up now.
And just a reminder while we get those questions up, if you do have any specific questions that we either don't answer or that you need clarification on, feel free to contact us. Our information is there on the screen. And also, if you do, in fact, have an audit and you need some assistance in a response or are interested in a mock audit, please contact us as well. We're going to jump right into the question.
When do we expect to hear back regarding hardship exceptions? Pat, I know this is an issue. The only people I know that have received any notification are if they had submitted for a hardship and they were clearly outside the need for a hardship. So they were either nurse practitioners who weren't eligible for Medicare and therefore weren't eligible for the penalties. If they were, say, just out of med school, categories that were clearly cut out from the need for the penalties and exceptions, they have received notices that they were not part of the mix and were not going to be subject to hardship. But for everybody else, honestly, I've not heard that anyone has received notice on the vast bulk. We had some systems that sent in, several dozen providers that they were still trying to meet stage 1, and we have not heard anything on those. So if any of you have received hardship notification, let us know. I'd be happy to share that with everyone.
Yeah, the one notifications that we have seen is when the more or less a rejection of the hardship. We've seen those come back through. So it's almost an assumption that you're approved if you don't get a rejection. So the next question is, what if it's our vendor's fault? Other offices can receive, but currently our system can't send out without getting an error. Now I'm going to assume this is a transition of care measure. If it is in fact the vendor's issue that you can't send out a TOC, that would be a system bug or a vendor-related issue that may allow you to step back to the 2013 standard.
Yeah, and Aaron, from what you're saying, I'm assuming that the problem is that your system cannot produce a CCDA that can be pushed out as part of a referral or a transition of care. And this clearly would be a functionality issue that would allow you to look back or, to move back. Either you don't say what stage you're at, but I assume if you're looking at CCDA transfer, you're at stage 2. You could either look back to stage 1 2014, so you'd report on your portal and your increased CQMs, or you'd look all the way back to 2013 and report on the 2013 measures. But if your only functionality issue is that you can't do transitions of care and your system can do the portal, I would say that your fallback is to the 2014 stage 1 measures.
Next two questions related to will the slides be emailed or available online, and will the presentation be available offline? Dottie will be sending out the slides to everybody in a PDF, and our goal is to post a recording of this webinar to YouTube, and we'll make that link available to everyone as well.
Yeah, and besides the handouts that we put together based upon questions from Monday, is we obviously have the slides which we're sending out to you. We have a handout which summarizes this all that you can use for your internal education or to talk about to your management or talk to your legal staff, whoever's going to have to approve look back. That is going to be included. We are also including information on EP immunization testing. So if you need to run the test, you know how to do it, since a lot of people did not do it in the past couple of years. That'll be included. It'll include screenshots of that and also registration information with the Department of Health. So if you need anything else, feel free to reach out to us, but hopefully that'll give you all the information you need.
If there are no more questions, we'll go ahead and wrap it up today.
Thank you all very much. We appreciate your attention.
Thanks, everyone.